It's now my pleasure to welcome our first panel of the day to the stage. Joining us will be Jennifer Bright, Chief Strategy and Engagement Officer of IVI, Christine Monkhouse, CEO and founder of Patient Orator, Karam Diaby, Director of Health Economics and Value Evidence Partnership, Otsuka Pharmaceutical Companies, and Jackie McRae, Director of Policy Research and Membership at Pharma. Please come to the stage. So this panel is the IVI Equity Initiative Key Findings and Recommendations. You've already gotten a bit of a teaser this morning from Jen, as she promised. She's going to give us a little bit of a deeper dive. And again, want to draw everyone's attention to the wonderful report that was issued last week and is available at the QR code. So we're going to go in the order in which people are seated. So we'll have Jen, then Christine, then Karam, and then, Jackie, and then Karam. Sorry, my bad. Jen, Christine, Jackie, and Karam, and then I'll come back with some Q&A. Great, thank you.
Thanks. Thanks, Elisa. Can everybody hear me okay? Okay, good. Well, I'm already invigorated. I don't know about you. And even if we are all talking to the converted, this is all part of the journey. And that's what I want to really share with you today is, as I said in my opening remarks, the work that IVI has been doing for over a year is a journey. We are not finished. As you heard Dr. Hughes say, this is something we're going to be talking about even 10 years hence. Our purpose in undertaking the Health Equity Initiative is to really emphasize where can we be taking action to make things different. And I think that is something that's part of the organization's DNA, but it's embedded as part of this initiative. We didn't take up this initiative or design it in any way to kind of get on a bandwagon or to give lip service to what we've been exploring. And our first order of business was to approach this with intentionality and with humility. And I think one of the things that makes this initiative unique is that we first started by asking questions, to Donna's point, and to, I think, Stacey, you asked the question, what are the questions we should be asking? That's how we started. We started by inviting a wonderful steering committee, many of whom are sitting with me on the stage, and others, and said, what should we be talking about? And these are people not just with expertise within the health technology assessment community, but within the health equity conversation writ large. So first we sought to learn. And then we started parsing out what are the questions we should be asking. So as I said earlier, and you can read this wonderful report, which I hope all of you will spend quality time with, we talked with over 40 stakeholders over the last year. That isn't the sum total, but we had intentional, structured conversations with over 40 people from all over the healthcare system: payers, clinicians, patients, family caregivers, people with deep, deep mathematical knowledge, to Donna's point, and incredible credentials. It's all very willing to have very candid conversations with us. And so where we have gotten to is, first, we sought to frame, when we talk about equity and its intersection with health technology assessment, what exactly are we talking about? Because we're not trying to own the entire universe of health equity. That's for CMMI to worry about. We need to really drill in on how do we create the intersection and how do we begin to frame out what work needs to be done. And so this report lays out some of where we've gotten to, which is to frame out 4 domains where we're really talking about how equity intersects with HTA. And those are power, people, and processes, the data inputs and infrastructure, methods, because we can't ignore the methods, and communications and use. Like Donna, I am not a methodologist. I'm not a health economist, although I've gotten a free training. Thank you very much for the last 5 years. But those domains, they intersect with the work and the granularity of the processes of health technology assessment. And they also frame out very nicely the areas in which we as a field have to get better at what we're doing. And so that's really the framing of this report and these findings. And then, so where are we in this journey? Donna very graciously gave us the mantra: no equity, no value. And we heard that very loudly in our first set of care informant interviews. And we talked to people who work with Native American communities. We talked with people that work at the Satcher Institute and looking at equity in mental health. We talked to a variety of people with far more credentials and immersion in these issues than I have. And these are the messages that we've heard across all these conversations. First, that we have to think about fundamental change. We are not talking about window dressing. We are not talking about adding a couple of patients to the conversation. We are not talking about magic math. We are talking about a whole constellation of things that need to change. So we need to think broadly about this field and how it needs to come up to current standards and current expectations in this conversation about equity. The second is that we have to talk about accountability. I mean, you heard Dr. Hughes talk about the way that CMMI is really taking seriously both their responsibility to lead and challenge others, but also to accountability. And we cannot wait for better data any longer. So, and then lastly, the other main message of our thinking is that we have to talk about mixed methods, which is what Donna really talked very eloquently about. I love the gardening metaphor. Thank you for adopting it. And so I, really want to challenge us to, in the rest of today's conversations, to explore all these areas. Happy to, add more depth to the work that we've been doing, but I'm really excited about having this conversation and to have the opportunity to talk with you about it. So, thank you.
Good morning, everyone. Can you hear me? Good morning. So I am Christine Monkhouse. I am a patient advocate, and I'm incredibly obsessed with solving for humanism in healthcare, but most importantly, making healthcare more accessible for humans, regardless of their race, et cetera. So my company is called Patient Orator, and we're a patient innovation focused on making it easier for people to tell their stories, specifically around social determinants of health, their individual values, and what it is that they need in order to access care much better, and making that patient provider communication more accessible. When I think about this work and when I was invited to be a part of this panel, I reflected back on my own patient journey and what that meant in the context of this conversation. And a lot of it comes down to the gaps in care that I've experienced. When I was in high school, I had healthcare, and then there were some gap years where I didn't have access to health insurance. And what that meant was that I didn't seek care because I didn't want to incur debt, medical debt specifically. And as I have matured and become a care partner to multiple people in my family, I've seen decisions being made not only by myself, but other individuals around how do we really make sure that these individuals are getting the care that they need without, again, the high economic burden that may or may not result. And I'll share a story about someone who I recently interviewed. And this is someone, his first name is Anthony, and I video interviewed him about his experience with healthcare. One of the things that he experienced was mental health condition, which landed him in the emergency room. And as a result of being there, he acquired medical debt. And the irony of the story is that while mental health is the reason why he's there, he aged out of insurance. He was no longer a part of his mother's health insurance. And what that meant was that the debt collectors were calling him consistently, causing even more anxiety for him. And so these are the things that are happening on the ground level and is very much relevant to the conversation around health equity. And we have to consider these individuals as it pertains to health technology, health equity, health access, et cetera. And I've read the report, and I will say that one of the things that I see very clearly and I appreciate is the fact that the patient voice is needed. And it should be a part of the conversations. It should be a part of the research process as well. In the design process, we need to get patient voices in early and as often as possible. And we need to also make sure that the questions are being co-developed and co-designed by patient advocates, by patients, and by individuals with lived experience with their healthcare journey. I'll pass it on to you now, Jacqueline. Thanks.
All right. Yeah, there we go. Thank you. How many researchers does it take to turn on a mic? All right. All right. Thank you guys so much for dealing with me with that. But again, my name is Jackie McCray. I have the pleasure of working at Pharma on health technology assessment and value. And I'm also a health economist and pharmacist by training. So our worlds definitely collide here. And so I was really honored to be a part of IVI's Health Equity Initiative. Anytime I have the chance to speak about health equity, I always like to reflect upon like what brought me to this passion place. As a budding pharmacy researcher, I had the experience of working with patients with diabetes who are receiving care from a free diabetes clinic. And I like to call them diabetes warriors because although they were marginalized and had so many barriers to access care, I mean, these patients showed in and week out to receive their healthcare services. And it really helps me kind of feel my passion to say that if we're not doing everything that we can to make sure that we're creating systems that are trustworthy, that are equitable, then really what are we doing in these conversations? So again, why does this matter for health equity and value assessment? So like I said, in my own research, I've really seen a couple of flaws that have even been highlighted within this health equity initiative and how these two worlds oftentimes don't collide. So firstly, when we think about the data inputs that are used within value assessment, oftentimes we're talking about averages. And so those averages are not telling the story of the folks on the margins, right? Because by nature of the mathematics, they're just not doing that. And so we need to look at heterogeneity more closely. Secondly, when we think about the value assessment process, again, with all of my training, I was really kind of shocked to see that within all of the evidence protocols and value assessment, there's no standards for the fact that equitable considerations or diverse patient representations need to be included within these assessments, which is really a flaw right from the start. And then thirdly, there's really this, I'd say, juxtaposition between health equity considerations, which oftentimes have their base in the social sciences and this quantitative world that we live in, right? That thinks that only types of data that matter are those that we can get from EHRs or from population health surveys, when we know that there's this whole other world that exists in qualitative research and mixed methods where we can call data just about anything, right? And so we need to incorporate data and lived experiences within that. I think that this conversation is particularly critical right now, given that we had the recent passage of the Inflation Reduction Act, which I'm sure we're all aware of in this room. We all may have our different feelings on the law and the implications, but I think we can all agree that CMS has a really great opportunity to ensure that the comparative effectiveness research used within the evaluations for the price setting methodology is equitable and fair, and incorporates a number of diverse perspectives in that process. And so one way that that could be done is, again, inviting stakeholders to the table as CMS is going through their process of evaluating the different evidence that is going to be used for price setting. And so then reflecting upon my work in IVI and Health Equity Initiative and thinking about those kind of key findings, I think the areas that I think are really transformative and I'd say like ground shaking is first off is just to say that there should be no equity without value. I think that that's a really great transition point for the field to say that we need these transformative shifts to be able to align these pillars more closely. Secondly, I think that although data can be just about anything, as I've learned from my qualitative research partners, we do need to make sure that we have granular data collection within quantitative research to ensure, as we were speaking about earlier, that we're not having broad brushstrokes as far as what we call health disparities, and we're able to actually ensure that we're not missing populations that are oftentimes invisible. And lastly, I think that where I would say I differ a little bit is that I'd love to see IVI talk more about the policy implications of this work, how policy really drives all of this, because like I said, again, if we're not acknowledging that, then we're not acknowledging the broader ecosystem. So I'll turn it to Karan.
Can you hear me now? Yeah, good morning, everyone. Thank you very much, Jackie, Jennifer. I'm very humbled to be here among this august audience today to discuss my perspective. I'm Karam Diaby. I'm a health economist and decision scientist by training. I was fortunate enough in my past life to join academia and now transition to the dark side, aka pharmaceutical companies. And so I guess my journey to the IVI, HEI has been both personal and professional. Personal in the sense that I was always vested into understanding value assessment frameworks when I was in academia and the implications in terms of data collection and how we could incorporate equity into those value assessment frameworks. And then joining pharma, I realized that for pharma, there's a lot of things to do in order to contribute to that debate. And so that put me in a very interesting position to not only provide my perspective, but also learn from that initiative. And so there are a number of initiatives that pharma could do to contribute to that debate, starting by incorporating early on in the drug development process the patient voice. And I think, fortunately, Otsuka is kind of doing that. You're going to say I'm actually doing the bidding for Otsuka right now. But to be honest, I'm very fortunate enough to see that occurring. So partnering with patient and patient advocacy groups to help translate what we do and empower patients. Number two would be to help also the debate about methodologies as part of HTA. And so pharma has a role to play in there. So engaging with the HTA bodies and help kind of understand a little bit better what are the nuances in terms of the methodology that could be used. Number three would be also to support any policy initiative that is aiming at facilitating, I would say, access to equitable and affordable drugs to patients. So those are the elements that I was very passionate enough to join this esteemed group, and I'm very happy to contribute today.
Thank you. I think we all now have the lived experience of the bad microphone. So we'll have that shared lived experience. I had the pleasure and honor of being the facilitator for two of the roundtables that we did that produced this report. And listening to the four of you this morning reminds me of those rich conversations, and we could probably spend all day talking about them. But I had a couple of questions I wanted to ask of each of you for a little bit of a highlights tour, and then we're going to open it up for audience and online questions. So, Christine, I want to start with you. The first topic that we tackled when we had the roundtable last fall was the power and the people domain. And I would very much appreciate hearing from you. Why is that so important to this discussion?
What a way to start the questions. I think I heard the previous speaker say that she speaks 3 different languages, even though English is her primary language. That is very much applicable to the patient voice. Even when patients speak English, they don't speak the same language as researchers does. Right. So let's start there. That in itself is a power dynamic.
Absolutely.
And I think that with all of the issues pertaining to trust in the many different communities, or the patient's trust or their inability to trust the healthcare system,
yes,
there's a lot of work that needs to be done in order to kind of equalize that dynamic, to make it easier for people to trust the system, trust researchers, trust whatever that equator is. So I think those are some things that could be done from that power standpoint.
That's great, and that's also this theme of looking upstream. We can't wait until a patient is in a paper gown on the table with a provider. We have to really think about creating a system upstream that then results in a better dynamic when that patient is in that vulnerable position with that provider. So thank you. Jackie, I wanted to unpack something that you said about policy. We're in DC, we can actually see the Capitol from here. Tell me a little bit more about when you put out that call to action to IVI, what comes to mind about policy?
Oh, yeah, great question. I think it's I guess 2 parts. One is acknowledging that we're all driven by incentives, right? And so these methodologies, these practices that we do as health technology researchers, they're all driven by the incentive process. And so I think we should just clearly state that, not just in the report, but when we're talking about things in general.
Right.
Because the policy implications here, one of them is access that patients have to medicines and technologies,
Right.
right? And so
Right.
patients should, even as they're invited to these conversations, they should understand clearly the implications of the work. And so I think we should kind of be singing that from the rooftops, right? There's implications that are going to happen as a result
Right.
of this. And I think secondly, when we think about policies, I mean, policies are everywhere, right? They're not just driven in Washington, D.C.
Right.
There's policies in publications and journals, unspoken policies in academia. I mean, there's policies everywhere, right? And so I think that we need to be transparent about those policies and how they relate to value assessment, so that again, folks can be transformed, and also so we can have a transparent process, right, in the policies and implications. So I just think that's such an important point that we shouldn't miss, because our work doesn't happen in a vacuum.
That's great. Thank you. That's a great segue to bring it to Jen. So this report, right? Reports are only as good as we use them, right? We used to say you don't want to produce a report and have it sit on the shelf. Now we don't want to produce a report and have it just sit on the internet, right? We want people to use the information in the report. We want it to become alive and have a future. We heard from Dr. Hughes this morning, kind of 1, 3, 5, 10 years. So Jen, as you hit, send on the report and disseminated it, what's something that you hope will come out of the dissemination of this report?
Thanks, Elisa. And so we built this to be an active tool. So if you go, I think maybe it was Stacy, said, what are the key questions that a patient can take in? Well, guess what? There are key questions listed in here. For example, and they're simple ones. For example,
What page are you on?
what page, whatever.
Just for reference.
The first question under Power, People, and Process is, who's doing this work and who's involved? And to what extent is the representation and participation of people with lived experience in the disease that you are exploring both represented in the process, and what impact did it have on the decisions that you made as a researcher to define the objectives, to decide what data you're using? And so we mean this report to be a tool, to give patient advocates. If you're a patient advocate, read it and look for questions that you can take to your next meeting. If you're a researcher, consider how you can change your process to include people up front, because as we heard Christine say, when you include people with lived experience, you start asking different questions. We had direct experience working with people living with major depressive disorder to help us design a patient preference study that we conducted with the PAVE Center at Maryland, and they fundamentally changed the way we were asking the questions and what the questions were that we were asking. So this notion of transforming health technology assessment is not a theoretical academic exercise. It is hand-to-hand combat, if that's the way you want to call it. And patient engagement is an action verb. It is not a checkbox. And so I would say that my vision for this report and for IVI's work is to do what Dr. Hughes challenged us, which is to help policymakers and those in power who have the resources and the ability to set incentives, see the how, see the granular ways that you can make small changes in what you're doing. And doing that will fundamentally, I think, have a ripple effect over time. It won't be overnight, and we can't pretend that it's not going to be complicated, but I think as a field, health technology assessment needs to stop labeling everything complex and infeasible, and we need to start addressing the root question, which is how can we make it feasible? So.
I think that's great, and I think even the terminology health technology assessment can create a barrier in someone's mind, right? It's to Donna's point earlier, oh no, that's math, I don't do math, right? But when we talk about looking at the value of something and determining, is this something that is appropriate for a patient or appropriate for a group of patients? That's really what we mean by health technology assessment. It's looking at the value of something and for whom it is most valuable. And as Donna said, if we don't have equity, we don't have value. I would also put, to Christine's point, if we don't have access, and I think Jackie, you mentioned this too, we can't have equity. And so they're all tied together in the healthcare ecosystem. So Karam, a question for you. As you listen to Jen talk about the report and you participated in the roundtables, what's something that comes to mind as an action step? So after our time together today, both here in the room and on Zoom, people are going to return to their busy lives, and we want it to be something that stays with people. Let's give everybody one thing they can do. What's something that comes to mind for you that's something that people can do in response to the work that IVI has done?
It's a tough question, but the simple answer to that is digest. A lot has been unpacked. As you did mention, there's a lot of evidence that has been generated,
Right.
culminated to this event today. So I think
Yes.
the first thing would be digesting and really looking into accountability. And accountability has two elements.
Okay.
Accountability for, which applies to everyone,
Right.
and then accountability from, which is leading by example. So
Great.
as a healthcare professional, I'm aware of my accountability. How can I make my fellow healthcare professionals aware of their accountability? So we have to be ambassadors ourselves. So everyone has a role to play. As Donna was mentioning earlier, everyone has a capability. So as long as we understand our roles and responsibilities, I think we can achieve that equity. And transparency is also another important point that
That's great.
emerged as part of this conversation, and transparency will have to do with especially marginalized population that lack trust in decision makers and researchers.
Yes.
And so open conversations would help kind of bridge that gap.
That's great. And your mention of marginalized populations brings me to Jackie's comment earlier, which is this can't just be about averages, right? Because then we lose the people that are on the margins. So as we think about this question, I'm going to come this way, which is, Jackie, what's one thing that you would like people to do, including your organization, in response to the IVI work?
That's good. I think I'll just tee off what someone said earlier, which is to continue to be curious. I think when you stop talking about health disparities, but talk about equity, it really just opens up a box of like all the potential implications, right? And so I think that we have to continue to be curious about not only what can we do now, but how can we learn from others, right? How can we assess what we're doing in 10 years and just continue to be curious about the potential implications or unintended consequences on even actions that we're making now. So I think it's really about curiosity and continuing to thread that needle.
That's great. And it sounds like also some reflection as one is curious. That's great.
Yeah, exactly. Yeah.
Thank you. Christine.
So I think that the report is excellent. It could be used for just a guidepost of where are you, right? I think you kicked us off with the word accountability, which is not what I had in mind, but it was literally what I was thinking was thinking about where your organization is and what it is that you can do as an individual leader to facilitate the change within the organization to meet the moment at this time.
That's great. Thanks. Jen, as you hear this, as the, in essence, author of the report, reflections from you.
This isn't going to get solved in one go. And I think there often I read media, stories about this, and it's implied that we have a formula for that, or there's a simple solution, or we can create one entity that will answer all our prayers. Basically, we've learned that's not the case, and even whether it's a federal agency or a longtime patient leader, we know that this is a journey. And so just listening to all these challenges, IVI isn't done. I mean, we're midway into this 2-year initiative that we set up. And what comes next is beginning to unpack within these domains the operational aspects of it. What does that mean? Who should take the action within an organization? Where, and most importantly, what Dr. Hughes said, I was glad to hear her give us that challenge because that's where our thinking is, which is where can we identify bright spots? Not to use that word, but where can we identify things that work? Where can we identify organizations that are doing what Karam is suggesting, which are being introspective and kind of saying, where can I lead? And that is important to the whole field. That helps all boats rise. That breeds trust. That proves that we can make change. And it's not this big, scary, awful thing. The world's not going to come to an end if we change health technology assessment as it's been done for the last, several decades. And that's where I think our focus is next, is how can we be the agents of change and where can we shine a light on what good looks like so that everybody can start leaning into that.
So I love that. And as I reflect on the report and the earlier conversations, one of the things that we spend a lot of time talking about is what can thwart us, right? What could hamper our efforts? What could stand in the way? And I'd like to channel my inner Dr. Hughes because she said she's an optimist. So what will facilitate us making progress? So a year from now, if we're gathered again, besides hoping that we have sun on the day as opposed to cloudy skies here in DC, what's something that in the next 365 days that could help facilitate us making progress? So to your point, Jen, it's not going to happen overnight, and we can't just wring our hands and say, oh, it's too hard, right? It's somewhere in between. We know it's going to take work. We know it's going to take time. So what can be an accelerant to getting to where we hope to go? So I'm going to start with Karam, and then we'll come back this way. So you get to be the period at the end of the sentence. Okay, Karam.
So Elisa, you're picking on me, yeah?
It's an opportunity, Karam.
No, I appreciate the question. This is a very interesting one. And I think there's one thing that was mentioned by Dr. Hughes that we have not really talked about a lot as part of the work that we have done, is really tracking and identifying metrics to measure our success. And that is related to your question. So 1 year from now, how do we know that we have achieved what we're supposed to achieve? So we have to be intentional in thinking about the metrics that we're going to be using. And I believe also in continuous assessment, which allows us to really think through the lessons that we learn and then incorporate that, readjust some of the steps that we have taken from the beginning.
That's great. I like you picked up on your own theme of accountability and you picked up on Jackie's theme also, right? So that's great. Jackie.
As the researcher in me, I think we've got to in some ways calculate the opportunity cost of what happens if we don't do this. We've got to make it real to folks. We need case examples, right? We need to do the work. I think this is where research can really shine to say, what happens when you don't incorporate these equity considerations? What happens when you don't incorporate diverse perspectives at the table? How much different do your results differ, right? I don't yet think that everyone believes that it matters. And so I think as folks in this room and others, right, we've got to prove that it matters with data. So I think that's where research can really shine.
So illustrations of both the value of doing it and the adverse consequence of not doing it.
Yeah, exactly.
Great. Thank you. Christine.
So I think just one action in 365 days would be great. But I think the question that we all should be asking ourselves, including myself as a health technology leader, is what can we do to accelerate shared decision making with our patients, to invite them in, and how are we really facilitating diverse patient voices? So the people that we're inviting in, making sure that they're reflective of the people that we're trying to solve for and or make things better for. And value has a different meaning to everyone.
Absolutely.
So those are some of the questions that I think we need to be asking. So there's plenty from that list that we can do at least one in the next 365 days.
I appreciate you raising the point about diverse patient voices. I don't know if anyone else was struck by Dr. Hughes's comment about individuals with disabilities And I mean, that was just mind-boggling, right? Like, they're the federal government. They have the data sets, and yet they don't know the details about individuals with disabilities, and then therefore don't know how best to provide them information, intervention, support. So I think your point, Christine, is a really important one. We have to make sure that those who need to be most included are included, even if we don't yet, I'll use a growth mindset, yet know everything we need to know. We need to work harder at that then. We need to be super intentional or uber intentional. So great, thank you. Jen?
I only get one question, one thing?
Maybe I'll get you two.
No, I'll take two. First, a colleague of mine said several weeks ago, questions are the work. And I think that all three of you have said that as well. Use this report to ask questions about what you're doing in your own organization and also ask others. I think we all need to be, I love ambassadors, but I'm going to go one step farther and say evangelists. I am a patient advocate at heart. I've worked in the mental health space for over 30 years. And so that's part of my DNA. And I would say, as a corollary to that, questions are the work. Ask the people who your work impacts. If you are not doing that, fundamentally, you are on the wrong track. That's the bottom line. I think that's the root of all of this. And I would say one of the things that has to change in order for us to see this happen is the power dynamics. I mean, we chose that word deliberately because we've heard it across the field of equity, but it's emblematic in the research world, in the constructs of academic research, in the primacy of clinical trial research, and all these things that have been around for decades. One of the things that will fundamentally change that power dynamic is when the money follows the philosophy that we're laying out here. So that means research funding is tied to research models, whatever, that can demonstrate that there are people with lived experience sitting at the table helping with code design. That will mean that journals would change their expectations and querying about submitted manuscripts to demonstrate evidence of patient involvement and impact on study design and things like that. And we see professional societies dipping their toe in it. As for published CHEERS, the Consolidated Health Economics Evaluation Reporting Standards. Boy, I got that. CHEERS, called CHEERS, which sounds very positive. But the only way that that is positive is if it's used. If it's used by academics, if it's used by research directors, if it's used by PCORI, if it's used by NIH, if it's used by CMS, in saying how are we directing the money and the decision power. If we don't use those tools, then we won't achieve what we're setting out to.
That's great. So in that, I heard a lot of the themes: accountability, transparency, asking the questions, being intentional, moving it upstream, and being evangelical about the process. That's great. So I've been a bit of a question monopolist here, so I'm going to stop and see if we have any questions here in the room or in the Zoom room. So yes, we'll get a microphone to you.
Hi, I'm Claire Sachs. I'm probably most of you guys' target demographic. I have 14 diseases and 40 years of patient and caregiver experience. And this is more of a comment than a question, talking about going to the root of it and building trust and being able to communicate and reach patients. I hate to go the opposite way of optimism, but I just wanted to say, expect setbacks. You're right, it's going to take a long time. It's going to take a lot of hard work, but existing patients, almost none of us have a clean slate when it comes to trust. We have all interacted at different levels and different volumes with every aspect of the healthcare system. And I hate to say it, but most of us have had our trust broken at least once. So when you are talking about doing all this hard work, please keep trying when we as patients push back.
Appreciate that comment. And I would not say that you are not being optimistic. I would say that you're being pragmatic. So thank you for that. Really important. Thank you for sharing. Other questions or comments here in the room? We have any online? Okay.
We answered all the questions.
Yes, here. Thank you. People want lunch, maybe.
I apologize on that regard.
No, please.
So mine is a formulating question, and I'm sure the committee has thought about it. I was thinking of the tagline that says, no value without equity, or no equity, no value. I was just trying to see if there's a positive spin about it, because when we read this, it still focuses on the mass market.
Yes.
Is there a way to kind of say, if you focus on building equity, you get extra value? Because we don't also want to penalize those things that focuses only on the marginalized.
That's a great point. Jen and others want to respond.
Seema, I would say I agree with you. I think that tagline and the whole report is about a mindset shift. And fundamentally, when that mindset shift happens or begins to occur, even if we have setbacks, Claire, it will change the field, it will change the way we use data, it will change the conversation, it will change the outcomes, it will change the trust. So it's a bit of a ripple effect. And I think we needed to be provocative to kind of plant the flag that you can't talk about value unless you are really addressing, incorporating, thinking about leaning in towards equity. And then other things will start to happen.
And I wanted to go back to something Jackie said too, which is, we're not talking about disparities, we're talking about equity, and that flips the mindset, right? So it's not just about saying, well, we have disparities and we want to close the gap. We're saying we want to create an equitable system, and the definition that CMS uses, which Dr. Hughes did an excellent job at, just, even though she said she wasn't going to get it 100%, I think she got 99.9%, which, is that everyone has the same access and ability to achieve their maximum health possible, irrespective of, a long list of characteristics and so forth. And I think that's an important piece here, is we're not talking about health technology assessment and health disparities. We're talking about health technology assessment and equity. And I think that's important. Jackie, do you want to unpack it a little more or comment more about why you called out that differential between disparities and equity?
Yeah, I think that they're firmly related, right? Because oftentimes we're talking about populations that have experienced health disparities, but at the same time, health equity at its core is a social justice principle. And so you can't use the word equity without calling on the fact that you're calling on social justice, which means that at your core, you've got to care about the marginalized populations, right? And so I think that you can't divorce those two topics. And so this is about justice, this is about fairness, this is about equity. And so we've got to keep those things together.
That's great. Thank you. I think we're coming up on time, so we'll do this a little bit like a, lightning round, 45 seconds each for closing remarks, call to action, anything you haven't yet had a chance to share. So we'll go Christine, Karam, Jackie, and Jen.
Wow, 45 seconds. There it goes. I think that including the patient voice is critical to this discussion. And the question that was just asked about not wanting to be exclusively focused on marginalized groups, there's a lot to unpack there, because if we can solve for people that are most vulnerable, we can solve for everybody.
Rising tide lifts all boats. Thank you. Great. Karam?
Yeah, thank you. So I would close my contribution by saying that we talked about a lot of actions to take, and I would like to also caution us to identify maybe few actions to really focus on. And there is a very interesting book that is Essentialism, the disciplined pursuit of doing less. By doing less, we are achieving more. And so we need to be very intentional in the actions that we want to prioritize. So that's where I'm going to stop today.
Great. Thank you. I'm putting it on my Audible to listen to list. Thank you. Jackie?
I guess my last consideration would be that, just like the report laid out, we all have our own specific roles to play in where we can help move this ball down the field. And so I think that just not becoming overwhelmed with all the different action steps and all the different players, but us all playing our role in our small piece of the world is important. So for example, I'm a researcher and I'm training in mixed methods to be able to apply some of these social experiences, right? Learning from colleagues who do this work in sociology, in gender feminism, et cetera, right? And so it's my piece of the world, but I think we all have a piece to play, and we can all learn from each other and borrow methods and borrow questions so that we can get better results.
Everyone has a homework assignment. No one's getting off free.
Exactly.
Great. Jen, bring us home.
Everything that was said, and health technology assessment has the opportunity to be an instrument of good in that it is a synthesis. It brings together a lot of components, people, experience, data, math. Sorry, Donna, math, policy. If we use it for the force of a learning environment and we try to stop implying that there is an answer or that there's one way of doing things, we will get farther in understanding the why behind why does X therapy have a different outcome for certain people versus others. How will we better use our resources to cover things like that the evidence tells us works, but we still are not delivering to people who live in communities that don't have access to mental health workforce, for example. These are the questions that challenge all of us. It has nothing to do with your political leaning, whether you're an evangelist for the quality or not. It is about learning. And if we treat it that way, then the implementation of all these action steps will begin to foster that. If we pretend that it's a model and a math equation that yields one answer that we can all put our bank on until the bank fails, we're gonna be talking about this for much longer than we should be.
So I'm standing between everyone and lunch or a break if you're online. So I'm going to wrap this up in a little bow, which is first and foremost, I want to commend IVI and our panelists and everyone who participated in the content and the recommendations in the report. The call to action is please don't let it just sit on the internet. Please read it. Take your piece. I think that's the homework assignment. There's something in there for everyone. There's a role for everyone to play. We're going to hold each other accountable. We're going to be transparent in our efforts, and we're going to keep the patient at the center of all of this in order to advance equity and that social justice. Please join me in thanking our panelists. For those of you who are here in Washington, we have a lunch break. We are convening back here at 12:59. And for those of you online, please take a break, and we welcome you back also at 12:59 for a 1 o'clock panel. Thank you.